Again. So, good evening, everyone. This evening, we are going to talk about the current understanding of the pathogenesis and treatment of membranous nephropathy. So, let's start by recapping some of the well-known concepts of membranous nephropathy. The first thing to say is that membranous nephropathy is the commonest cause of nephrotic syndrome in the adults. It presents typically with heavy proteinuria, and most patients have nephrotic syndrome, but do not have any hematuria, hypertension, or renal insufficiency at the time of presentation. Uh, the diagnosis of nephrotic syndrome is made usually only on kidney biopsy so far, but that is likely to change over the coming months and years. And the characteristic features on kidney biopsy are: on light microscopy, you can see basement membrane thickening, immune deposits on the epithelial side of glomerular basement membrane on electron microscopy, and if you do immunofluorescence, you will find immunoglobulin G, which is both IgG4 and IgG1. Along with that, you will find the lytic complement pathway C5b to 9 complex. Now, a subset of patients develop progressive kidney dysfunction, and the current management strategy requires use of immunosuppressive drugs in patients who are at high risk of disease progression. Now, traditionally, we have divided membranous nephropathy into idiopathic membranous nephropathy, which is an autoimmune disease and is a diagnosis of exclusion once we have excluded all the secondary causes of membranous nephropathy, where the antigen is actually exogenous. These antigen could be either viruses like hepatitis B, C, or tumors in the case of cancer-associated membranous nephropathy. But the concept of idiopathic membranous nephropathy is also changing, as we'll see in a moment. Now, the other known fact about membranous nephropathy is the management strategy. According to the KDIGO 2012 glomerulonephritis management guidelines, the recommendation was to use a 6-month course of alternating monthly cycles of oral and intravenous corticosteroids and oral alkylating agents. Now, this was only if the patients who had been managed conservatively for at least 6 months and had not shown any response in the proteinuria, in the sense that they continued to be grossly nephrotic, or that they developed any complication of nephrotic syndrome, such as venous thrombosis, arterial thrombosis, or severe edema, or progressive kidney dysfunction. Now, in the alkylating agent, cyclophosphamide was recommended to be preferred over chlorambucil by the KDIGO guideline. And the basis for making that recommendation were 2 large studies, one of which was ours, actually, which was published in JASN in 2007. Before that, in 1989, we had the study by Claudio Ponticelli et al., which gave rise to the Ponticelli regimen, which was on alternating monthly cycles of 3 days of methylprednisolone followed by 27 days of oral prednisolone, alternating with chlorambucil. And what we did is we modified that and used cyclophosphamide. And what we showed was that looking at various types of endpoints, and this was a 10-year follow-up data that we presented in this paper, probability of survival without dialysis, probability of survival without reaching any endpoint, entering into complete remission, and any complete or partial remission was better in patients who were treated with cyclophosphamide prednisolone combination. Now, so what happened after the KDIGO guidelines were published? So in 2013, which was after publication of the KDIGO guideline, came one more paper, which was from UK, which compared 3 different types of treatment strategies. So one group received supportive therapy alone, which means they did not receive any immunosuppressive therapy. The second group received prednisolone and chlorambucil, which is the Ponticelli regimen. And the third group received cyclosporine, which is calcineurin inhibitor, which had become popular by that time. And please note that the number of subjects recruited in this study was really, really small. So 37, 33, and 36 in these 3 arms. And what they also found was that patients who received supportive therapy only, or patients who received cyclosporine, actually showed a lesser time to decline in 20% GFR, which means patients who had received prednisolone or chlorambucil actually took much longer to show 20% decline in GFR, which means this was a prednisolone and chlorambucil treatment regime was superior to cyclosporine and supportive therapy only. Now, by this time, the use of calcineurin inhibitors was growing especially in North America, and subsequently from different parts of the world, data on use of calcineurin inhibitors came along, and our group, led by Dr. Raja Ramachandran from PGI Chandigarh, actually was one of the first ones to make this comparison. So this paper was published in 2016, where tacrolimus combined with corticosteroids was compared with modified Ponticelli regimen. And here is a follow-up paper which appeared just recently, which showed 2-year data of the same paper. And what was the conclusion? At 2 years after randomization, relapse rates were higher for tacrolimus treated patients compared with cyclophosphamide treated patients. So the summary, and this data has been replicated from several centers around the world, is that even though patients with membranous nephropathy, while treated with calcineurin inhibitors, are able to enter remission, most of the patients are unable to maintain their remission, and tacrolimus or cyclosporine associated with more than 40% relapse rate. At the same time, we have seen a shift in the diagnostic monitoring approach as well as classification of patients with membranous nephropathy. And this was really kick-started by this paper which appeared in New England Journal of Medicine from the group of David Salant from Boston University, which identified this particular protein, which is the phospholipase A2 receptor protein, as one of the putative antigens of idiopathic, so-called idiopathic membranous nephropathy. And since then, we have had a second antigen identified, which is the thrombospondin type 1 domain. And so these are the two new antigens which have been identified as the causative agents of membranous nephropathy. Now, how do you identify antibodies to these two antigens? So let's take the example of phospholipase A2 receptor antibody. So you can use two techniques to identify these antibodies in circulation. The more sensitive technique is the technique of indirect immunofluorescence, in which you have 293 T cells which express the phospholipase A2 receptor, and when you put the patient serum which has this antibody, then the antibody will bind to this antigen, and you can come in with a secondary antibody which is conjugated with a molecule which emits fluorescence, and you can detect it. Now the second method is ELISA technique, in which the antigen, in this case phospholipase A2 receptor antigen, is actually coated on a glass plate, and on the glass plate you have the primary antibody, which is the patient serum, and if the antibody is present, it will bind to this antigen, and then you can come in with a secondary antibody conjugate, which will again lead to a signal. So these are the two ways of identifying the phospholipase A2 receptor antibody. Now, since the time it was discovered, a meta-analysis was published in 2014, which included 15 studies with more than 2,200 patients. And the meta-analysis showed that if the antibody is present, it is associated with a specificity of 99% for the diagnosis of membranous nephropathy. But if it is absent, you can't rule it out with that degree of certainty, and the sensitivity is only about 78%. So the initial Salant paper actually showed that anti-phospholipase A2 receptor antibody identified a glomerular protein of the same size as by the sera of patients with idiopathic membranous nephropathy, as was defined at that time, and that all such sera recognized also recombinant human phospholipase A2 receptor molecule. Then what they did is that they performed immunoprecipitation experiments using human glomerular extract, which was incubated with sera, and they found that these immunoprecipitates were recognized by anti-phospholipase A2 receptor antibody on Western blots. Then they went on to show that phospholipase A2 receptor was expressed on glomerular podocytes. This was an important finding to show, because earlier, many years ago, megalin had been proposed as a putative antigen for membranous nephropathy, but one catch was that megalin was not at all expressed by glomerular podocytes, whereas it was expressed by tubular cells. So if a molecule is or antigen is not expressed on glomeruli, it is unlikely to be really the causative agent of membranous nephropathy or any other glomerular disease for that matter. And the final thing they showed was that the phospholipase A2 receptor and immunoglobulin G4, which is the most frequent type of or subtype of IgG in idiopathic membranous nephropathy, they localized in the immune complexes in idiopathic membranous nephropathy patient. So to cut a long story short, we now have certain recommendations for a good usage of serological tests for phospholipase A2 receptor. So how do you do that? The first thing is that if you want to use a screening test, immunofluorescence is better because it is more sensitive than ELISA. But ELISA is much more useful for monitoring because you have a titer and you can follow the titer. Immunofluorescence positivity persists longer. Hence, immunological remission requires a completely negative immunofluorescence result. Now, it is that I want to introduce a new concept to some of you, which is the concept of a sink effect. So, what is a sink? A sink is something in which if you can throw some water or some liquid, it just disappears down the drain. So, what it means is that kidney is acting in this situation like a sink. Say, for example, normally you expect the antiphospholipase A2 receptor antibody to be present in circulation, but it may happen in some instances that all the antibody which is present in circulation actually goes and binds with the kidney, and so all the antibody is used up and you do not find any antibody in circulation. So in this situation, the circulating antibody may be falsely negative because kidney is acting as a sink. The second situation in which the circulating antibody may be negative is if the patient has developed a spontaneous remission before any treatment at all. So these are the two situations where a patient, if you do a kidney biopsy, the patient has the patient has membranous nephropathy, and if you do antibody, you find the antibody is negative. But to eliminate the possibility of sink effect, you will need to look for antigen in the kidney biopsy. So it's important to look for the phospholipase A2 receptor antigen on kidney biopsy, antibody on the kidney biopsy. So this is an example of which illustrates the sink effect. So this is a paper which appeared in New England Journal of Medicine in 2011 from the group of Pierre Ronco from France. Paris in France. So Ronco's group identified 3 groups of individuals with membranous nephropathy. So you can have a certain number of subjects who are serum antiphospholipase A2 receptor antibody positive and also show staining for the antibody in glomeruli. This is the largest group of subjects. You can have a group of subjects who have serum antiphospholipase A2 receptor antibody positivity but do not show staining for antiphospholipase A2 receptor in the glomeruli. That's a small number of subjects. You may have still a number of subjects with idiopathic membranous nephropathy who have both serum antiphospholipase A2 receptor antibody absent and no staining on the kidneys. These group of subjects are likely to have another antigen. In some cases, we know that it is now THS7DA. Then in third group of subjects, you have staining in the kidneys, but serum antibody is negative. This is the kidney as a sink phenomenon. This is what it represents. So now we are more or less reaching an antigen-based classification of membranous nephropathy, in which you have more than 80 to 85% of patients with membranous nephropathy due to phospholipase A2 receptor antibody related. So which means antibody either in the serum or on kidney biopsy. Less than 5% have this THSD7A antigen related. About 10% do not have either of the two forms of antibodies, and so possibly there is a third antigen. Now, here is an important difference. So now primary does not mean that the patient has to have phospholipase A2 receptor antibody negative, because it has been shown that a number of subjects have phospholipase A2 receptor antibody positive membranous nephropathy, but they also have hepatitis B, hepatitis C, sarcoid, or cancer. In some cases, some patients with cancer and membranous nephropathy have also shown THDS7A antigen as well. So that's really important. So primary is only where you have all these antibodies or no antibody but no etiology. Secondary, you know the etiology, but the antibody may still be present. This is important. So the lesson here is that you in patients where you find a secondary cause, go ahead and treat the suspected cause. But please remember that these patients may still have phospholipase A2 receptor antibody associated membranous nephropathy, which may require the use of immunosuppressive therapy. This is illustrated in this patient, which was reported by Dr. Ramachandran and colleagues, which presented with nephrotic syndrome, was biopsied, was found to have membranous nephropathy, which was phospholipase A2 receptor antibody positive, and the serum phospholipase A2 receptor antibody level was also quite high, but the patient was hepatitis C virus positive. The patient was first treated with antiviral agents, and in the initial instance, the phospholipase A2 receptor antibody titer came down, but the proteinuria continued to persist. Once the hepatitis C virus was treated and it became negative, we found that the proteinuria was still persisting. So at this time, the phospholipase A2 receptor antibody had come back. And here we decided to go ahead and Dr. Ramachandran treated this patient with the modified Ponticelli regimen. The patient responded, developed both decline in the antibody titers, and the proteinuria became 0.2 grams, which means the patient entered a complete remission. So this is something which is an important lesson. There are two important questions now in the treatment of membranous nephropathy, and let's try and see if we can answer them better. The first question is, who should we treat, when should we treat, and how long should we treat with immunosuppressive agents? And the second question is that normally we recommend that all patients with membranous nephropathy should be treated with ACE inhibitors and statins, etc., for at least 6 months to see whether they can enter complete remission. Can we shorten this period for patients who are at high risk of progression? So this ties into the second question, which is how predictable is the outcome of membranous nephropathy? And as I said before, we have the rule of 1/3, which means 1/3 will develop spontaneous remission, 1/3 will progress to ESRD, and 1/3 will have some degree of persistent proteinuria and maybe some decline in kidney function, but will never develop ESRD. And the clinical predictors of membranous nephropathy are well known and are written here. We also know that the quality of remission is important. Patients who enter complete remission are likely to do much better, and patients who enter only partial remission exhibit a higher relapse rate. And now we have come to understand that the presence of phospholipase A2 receptor and THSD7A antibodies are also important in predicting the outcome of membranous nephropathy. So we have a number of studies which show now that at presentation, if the phospholipase A2 receptor antibody level is high, it is associated with a lower rate of remission. It is also associated with a higher risk of development of nephrotic syndrome in patient who was non-nephrotic at the time of presentation, and also with a high rate of renal function deterioration. If you treat these patients with immunosuppressive treatment, these patients who are antibody positive will take longer time to respond. And this is something which was shown in this paper from Italy, in which patients who were phospholipase A2 receptor antibody positive were treated with Rituximab. What they did is that they divided patients into 3 tertiles based on the phospholipase A2 receptor antibody level, and patients who had the highest level of antibody actually were much less likely to progress to combined endpoint, which was that of response to treatment. And you know, and this slide shows, or this part of the figure shows the proportion of patients who entered complete remission, which is also lowest in the group with the highest antibody titers. So now we have entered the era of a new membranous nephropathy management algorithm, and this is an algorithm which was proposed by Dan Catran, who was really a strong proponent of using proteinuria as a risk factor and predictor. So Dr. Catran said that if proteinuria is mild, just treat with ACE inhibitor, angiotensin receptor blocker, make sure the blood pressure is less than 125 and 75 and monitor. If the proteinuria is moderate again, and kidney function is normal, and phospholipase A2 receptor antibody is in mid-range, again treat with supportive therapy, keep the blood pressure down. But if the proteinuria persists, then treat with cytotoxic drugs and steroids or CNI or rituximab according to him. If the proteinuria is heavy and if the phospholipase A2 receptor antibody is high, if you have treated with ACE inhibitors, etc., and here in the middle group, the monitoring was recommended for 6 months, but here in the high risk group, the monitoring is recommended for less than 3 months. If the proteinuria persists, again go ahead and treat with cytotoxic and steroids, rituximab or CNI. We are now actually moving forward from this also, as we'll see in a moment. So now let's look at the new studies which have subsequently appeared. So let's look at this GEM-RETUX study. And this is the study design. So here you have patients who for 6 months they received a non-specific antiproteinuric therapy, and then they were randomized to receive either rituximab or to continue on non-specific antiproteinuric therapy alone. Patients who were randomized to receive rituximab received 2 doses of rituximab on day 1 and on day 8 at the dose of 375 milligram per meter square intravenous. And antiphospholipase A2 receptor antibodies were measured at these time points, day 0, day 8, month 3, and month 6. And CD19 counts were measured at month 3 and month 6. Okay, so this is something which is important. So what did they find? Here are the key findings. The key findings were that when they looked at the serum antiphospholipase A2 receptor antibody level, patients who had received rituximab were much more likely to show a decline in the antibody level both at month 3 and at month 6 compared to patients who were treated with non-specific antiproteinuric therapy alone. And when they looked at patients who received remission, either complete or partial, again that proportion was much greater in patients who were treated with rituximab. Okay, so that's important. Now the second study I want to point out is the MENTOR study, in which membranous nephropathy patients have been randomized to receive either rituximab or cyclosporine A, and various endpoints have been looked at here. And these are some of the results initially. So this is time to partial or complete remission, and they found that there was no difference in the cumulative incidence between those who received cyclosporine and those who received rituximab. Please note that this is only 12-month data and the study is still ongoing. And they also compared time to treatment failure. And please note that here rituximab did better than cyclosporine, because as I described before, even though the response is good with cyclosporine initially, as you can see here, over a period of time, many of these patients continue to relapse, and therefore they were considered to be developing treatment failure. Okay, so this is something which is important. Now, the third thing that we are always concerned about is the safety of the treatment that we give. So we do know that steroids and cyclophosphamide is a potentially toxic treatment combination. You have to make sure that all patients who receive this do receive appropriate infection prophylaxis. So they receive Septran, and we tell them to be careful. We tell them to use chlorhexidine mouthwash. We tell them to continue to use alcohol hand wash, and make sure that they protect themselves against infection. So in this paper, which appeared earlier this year, they looked at the number of adverse events and found that those who received cyclophosphamide actually had much greater likelihood of developing adverse events compared to rituximab, both any type of adverse events and serious adverse events. So this is not something which is a big surprise to us. The next question that we want to know is that what is the most effective dose of rituximab in achieving and maintaining remission in membranous nephropathy? And this is a paper which was presented in the ASN Renal Week just last month, where they tried different dosage. So they found that rituximab on the current dosage, which is used in the GEM-RETUX study, which is 375 milligram per meter square on day 1 and day 7, is actually less effective in reducing antiphospholipase A2 receptor antibodies. So we need to develop alternative strategies. Now, the next question is, can we monitor and predict clinical relapse? So the answer to that seems to be yes, that now that we have antiphospholipase A2 receptor antibody, which is shown in this line, you can see that this precedes the development of urinary remission, which is the 24-hour urinary proteinuria, and this coincides with the CD20 count. So the CD20 count falls very rapidly after rituximab is given, and this is followed by reduction in antiphospholipase A2 receptor antibody, which is followed by reduction in proteinuria. Please note that the CD20 count starts to recover after about between 3 and 6 months, and slowly it comes back, and it comes back to more or less baseline after about 1 to 1.5 years. So this is something which is important for us to remember. And finally, serum albumin improves as the proteinuria declines. It has also been shown that if a patient has initially shown a decrease in antiphospholipase A2 receptor antibody titer, but if the antibody titer subsequently increases, or if it had disappeared but reemerges, then this increase or reemergence is associated with a high risk of relapse, which is shown in this particular paper, again from Italy. We showed that if there was no increase, much less likelihood of relapse of nephrotic syndrome compared to those who showed an increase, or who showed a re-emergence, again had a higher risk of relapse. This is something which was shown again from PGI in the study done by Dr. Ramachandran, which is shown here, in which we looked at the antiphospholipase A2 receptor antibody titer at baseline, and at 6 months you can see the decline, which was followed by a decline in the proteinuria. So now people have started to develop algorithms on developing serology-based approach to diagnosis, management, as well as prognostication of membranous nephropathy. So let's look at this diagnostic approach. So now it is likely that if you have a patient in whom you clinically suspect membranous nephropathy, because this is a patient who's adult, who has a gross nephrotic state, does not have hematuria, does not have hypertension, does not have renal insufficiency. So the recommendation could be that the first thing to do here is to measure the phospholipase A2 receptor antibody titer. And if the titer is positive, look for secondary causes. If there are no secondary disease, then you can assume that this patient has phospholipase A2 receptor antibody associated with membranous nephropathy, because as I said before, the specificity is greater than 99%. If the patient, however, is antibody negative, excuse me, then you need to perform a kidney biopsy and stain for phospholipase A2 receptor antigen to look for the sink effect. All right. So here, let's assume that it is you find the antibody is positive, and the immunoglobulin type is IgG4. Once again, you can make a diagnosis of PLA2R receptor associated membranous nephropathy. If the antibody is negative, antigen is negative, but IgG4 is still present, look for the second antigen. You can measure serum THSD7A antibody and stain for THSD7A antigen, and it may be either positive or negative. If you have PLA2AR antigen negative and IgG4 is not present, then this is most likely a secondary membranous nephropathy, in which you can aggressively screen for cancer. Okay, so this is about diagnostic approach. Now let's look at the prognostic algorithm. So you have to look for three things here: the antibody titer, proteinuria, and serum creatinine. If you have high level of phospholipase A2 receptor antibody titer and any level of proteinuria, you should follow the antibody titer every month. If the titer continues to increase, start immunosuppressive therapy. If the titer declines, then the patient goes into this group, which is moderate to low antibody titer. Then you should follow the antibody titer and proteinuria maybe once every 2 months. If the patient has continues to have nephrotic syndrome, look at titers. If the titer either does not decrease or in fact increases, start immunosuppressive therapy. But if the titer decreases, continue to follow the patient on conservative therapy. If the proteinuria is non-nephrotic range and the titer increases, then again start immunosuppressive therapy. But if the proteinuria is a non-nephrotic range and titer either remains stable or decreases, again follow conservatively by bi-monthly monitoring of antibody titer and proteinuria. Now let's come to treatment algorithm. Once you have started immunosuppressive treatment, the recommendation from this group is to follow the antibody titer bi-monthly. But here, according to the experience that Dr. Ramachandran and others have had at PGI, it is recommended to monitor the titers every month. If the antibody response shows greater than 90% in less than 6 months, you should stop immunosuppressive therapy. If there is no response and there is less than 50% reduction, maybe modify immunosuppressive therapy and continue for longer. But if there is even lower reduction, continue the immunosuppressive therapy for longer. Now here is the recommendation which is proposed by Dr. Ramachandran and our group. So according to this, treat patients, then you start with the second month of therapy and follow the antibody titer monthly. If the antibody titer becomes negative at any time, then treat the patient for 1 month after the antibody titer has become negative. And if the next antibody titer is also negative, then stop immunosuppression, but continue ACE inhibitor and angiotensin receptor blocker. On the other hand, if the patient has antibody still positive at 6 months, then the patient has a resistant disease and maybe will require a second-line therapy, which could be rituximab or some other agent. So this is the summary of this, the behavior between antibody and clinical disease. So you have antiphospholipase A2 antibody high, you have proteinuria. So this is both immunological disease and clinical disease in the initial stages. Now, it is possible that once you treat, the phospholipase A2 antibody receptor titer decreases and becomes negative. Proteinuria will decrease more slowly and either may disappear completely, in which case the patient would have entered complete remission, or may enter partial remission. All right, and then it is possible that at least a small proportion of patients will show a repeat increase in the phospholipase A2 receptor antibody titer, which may actually reflect in recurrence of the nephrotic syndrome, so which will cause a relapse of the disease. Okay. So having dealt with all this, let's look at some very recently emerging information on a more improved understanding of how the PLA2R epitope. So PLA2R is a molecule. So the whole molecule is not the antigen, as we know from our basic immunology, that in the immunological reaction there is an antigenic epitope. So in the PLA2R1, there is an antigenic epitope, and there is this concept of epitope spreading. So let's see what is epitope spreading. So you have, in any immunological condition, you have a primary epitope, all right, against which the immune system has led to a generation of antibodies. So this will lead to, forget the greater details of this, this will lead to immunological reaction, all the cells will come in, and they will lead to tissue destruction. Once there is tissue destruction, there is tissue debris. And so once the debris is there, then a lot of antigenic epitopes, which were so far hidden, actually get exposed. And then the new antibody starts developing against these epitopes. And this is the phenomenon which is called epitope spreading. So you have now a secondary epitope, which also gives rise to antibody formation. This is an important phenomenon which has now been exploited in the case of membranous nephropathy. So this is a paper which was published in the last 2 weeks in JASN, in which they looked at epitope spreading in patients with membranous nephropathy. And what they showed is that, so look at these subjects. So you have these different colored dots that you see here. So you have this black dot in which there is no epitope spreading. And you have these other dots, red, blue, and green, in which you have three different types of epitope spreading. So they looked at outcome of patients who were treated with rituximab, and patients who did not have epitope spreading, they were much more likely to respond to treatment. Okay, this is what you can see here. So you have month 0 remission patients, much higher likelihood of no epitope spreading, but month 0, if you have epitope spreading, then no remission. And here are patients who did not develop remission, much higher likelihood of epitope spreading. Okay, so this is at month 0, and the same phenomenon at month 3 when they looked at the antibodies. And here they looked at outcome of this was the outcome of month 6, and this was the outcome at last follow-up. More or less similar type of result, even more impressive in terms of patients who did not have epitope spreading were much more likely to enter remission. So what does this mean? This means that it is possible that we can identify patients who are at greater risk of not entering remissions, spontaneous remission at least, if you look for epitope spreading. I mean, this is right now, this is experimental, this is not proved, and this is not likely to enter clinical practice very soon, but this is something which you should know of. So this is again data from the same paper. So here were patients who were treated with non-specific antiproteinuric therapy, and here were patients who were treated with Rituximab. And so patients who were treated only with non-specific immunosuppressive therapy, and if they had no spreading, they were likely to enter remission. Whereas if they showed spreading, they were much less likely to develop clinical remission. On the other hand, if you identify these subjects and if you treat them with Rituximab, they are more likely, although not as likely as patients who do not have spreading, but they are much more likely compared to patients who are treated only with non-specific therapy to enter remission. So what it means is that if you are able to identify patients with epitope spreading, then you can potentially identify high-risk patients who are less likely to respond with supportive therapy alone. All right. So what does it all mean? Where we might be headed now? So according to Dr. Pierre Ronco, who is one of the who heads one of the groups that has done the largest amount of work in this, any immunological reaction remission should be defined by the disappearance of antiphospholipase A2 receptor antibody, ideally by immunofluorescence, but that is something which is not possible. But so in our circumstance, we should definitely do ELISA. Of course, complete clinical remission is easy to define because patients enter into no proteinuria and so on. Partial remission and relapse relies on proteinuria, which is highly variable, and this is where antiphospholipase A2 receptor becomes important, and it should be considered in the definition of disease remission now potentially. Long-term complete remission without relapse remains the ultimate goal of treatment in patients with membranous nephropathy. However, until the patient develops clinical remission, complete clinical remission, we can also aim at immunological remission, complete immunological remission, which means undetectable antibody, which will precede clinical remission by several weeks or months. All right. But there are a number of still unresolved questions and future challenges. We still need to understand better remission, disease progression, and disease recurrence. As I described to you, we have now the need to revisit membranous nephropathy classification based on antigens because causes are shared. We need to actually develop our understanding of epitope analysis, and we need to actually look at the predictive value of spreading. Of course, as I said, about 10% of patients with membranous nephropathy, we still cannot identify the antigen, which we need to do now. We need to identify T cell epitopes and replicate Treg data, which I did not show you. We need to develop new therapeutic compounds, treatment strategies, and so on. But the bottom line is that right now, the most effective treatment still remains the use of alkylating agents such as cyclophosphamide in combination with steroids. And so with the use of appropriate safeguards against infection and so on, it is certainly much more effective in inducing complete remission and in minimizing the likelihood of relapse in patients with membranous nephropathy. However, if you have a patient who is very young, for example, still in a childbearing age and willing to have and wanting to actually have children, then in such patients, use of Rituximab might be a consideration. But please remember that Rituximab is right now not really proved with long-term data, whereas the long-term effectiveness of cyclophosphamide-based therapies has been well established. We also know that there are a number of genetic factors which have been identified, And this was the data which was published again about 7-8 years ago from Europe, which identified some high risk alleles in the DQA1 locus and phospholipase A2 receptor locus, which is very well expected. And this is data from the European cohort, which shows that if both the high risk allele in the phospholipase A2 receptor and DQ1 antigen is present, then such a patient is almost 80 times at increased risk of developing membranous nephropathy. Now, we also looked at, again, Dr. Ramchandran, etc., looked at this data, and we more or less replicated similar findings. And what we found is that if both of these high-risk alleles are present, then in Indian context, the risk of development of membranous nephropathy is 58 times increased. Now, the most recent data that is coming up and is relevant to India is from China, which looked at the risk of development of membranous nephropathy and air pollution, exposure to air pollution. So what they first of all found is that in China, the prevalence of membranous nephropathy was actually increasing over time from 2004 to 2014. This is data. You can see that the number of patients with membranous nephropathy is increasing, whereas all the other diseases like IgA nephropathy, minimal change, lupus nephritis, FSGS, and HSP nephritis, they remain stable. And then they went on to look at air quality in different regions and the prevalence of membranous nephropathy in that region. And they were able to show actually a direct correlation between exposure to air pollution and the risk of membranous nephropathy in different parts of China. So this does not establish a cause and effect relationship. This is only associative, but this is very thought-provoking. And in light of our understanding of the effect of environment of disease, this opens up a new field of research on trying to see if we can find similar association elsewhere in the world as well, and particularly in India, because air pollution is a major problem, emerging problem in India over the last 2 years. And we do see a large number of patients with membranous nephropathy. So we need to systematically look at the geographic spread of our patients and establish any such relationship. So thank you very much for your attention, and I'm